So I'm supposed to introduce the next speaker, Lorenzi. She is our very dedicated, very passionate neurodevelopmental psychologist that we use with our patient population.
Hello, thank you so much for inviting me to participate in today's course. I will be speaking today on neurodevelopmental care implications in the early stages of univentricular heart palliation. My name is Lorenzi Quigley, and I am a psychologist in the Heart Institute here at Children's in Pittsburgh and the director of our cardiac neurodevelopmental care program. Early stages of care for this patient population with complex CHD is occurring within critical periods for brain growth and maturation, myelination, development of neural networks, and beyond. And the altered cerebral blood flow and brain immaturity during these sensitive developmental periods can lead to increased risk of developmental delay and susceptibility to injury. Along with the medical, surgical, and catheter-based interventions in this period, this can have implications for neurodevelopmental outcomes, which we'll discuss today. The prevalence of neurodevelopmental impairment in the population with congenital heart disease does range based on severity of the diagnosis, with the highest rates of neurodevelopmental delay or disability in our univentricular heart population, along with those with corresponding genetic diagnoses. It's estimated that 50 to 75% of children with complex CHD are affected and report some degree of reduced quality of life. We see the implications in various arenas of development, sometimes in terms of cognitive functioning and with lower IQ quotients, in terms of later academic achievement, language skills, both expressive and receptive. Visual spatial functioning is largely impacted in a large portion of this patient population, along with attention and executive functioning challenges, fine and gross motor abilities, and psychosocial maladjustment, both in regards to internalizing and externalizing problems. This period of infancy, much of which can be occurring in a hospital setting, comes along with high levels of stress and distress for both the patient, but also for the family, with heightened sensitivity for the infant to light, sound, smell, and touch. There are corresponding difficulties with early neurobehavioral and regulatory capabilities, which can be seen in feeding practices and sleeping, settling, soothing, in addition to autonomic and motor organization. And this can all have implications for early bonding and parental engagement. So what can we do and how can we support these patients and these families? And a lot of this comes down to developmental care frameworks, much of which has originated in NICU environments and is based on a maturation paradigm where premature infants show increasing behavioral organization over time and increasing gestational periods. But these can certainly be applied to that of the critical CHD child as well. This is a broad category of interventions designed to minimize stress in an ICU setting by providing structured care environments and being thoughtful about these various arenas here, including safeguarding of sleep, environmental support guidelines, positioning and handling of the infant, minimization of stress and pain, developmentally appropriate stimulation, as well as family-centered care. All of these interventions are designed to support, encourage, and guide the developmental organization of the critically ill infant, and we are seeing further research, especially in the CHD population, to show the positive impacts of these interventions in terms of neurodevelopmental implications, even in terms of length of stay, and notably in terms of parental stress and parental involvement in care. We can see the growing literature base in this arena showing the positive implications of individualized, family-centered developmental care practices in cardiac intensive care units. And the growth of this research has really been helpful in how we can best support these patients, especially in this interstage and early period. Individualized family-centered developmental care has really been explored by the Cardiac Neurodevelopmental Outcomes Collaborative, and really work to unpack how we can implement some of these, as I mentioned, NICU originating interventions in a CICU environment. We really look at parent engagement and care as a core component of family-centered developmental care, but also these other arenas that were discussed previously of safeguarding sleep, minimizing stress and pain, non-pharmacological interventions for pain, and as well as sensitive and cue-based feeding protocols. So speaking to the family-centered care portion of this, we know that infants born with complex CHD are almost immediately physically separated from their parents, often physiologically unstable in the early periods, and are transferred very quickly to ICU settings for often very quick intervention. This can lead to inconsistency in physical closeness between the parents and the infants, reduced opportunities for parents and caregiving, and this has impacts on parental feelings of powerlessness. A prolonged inability to hold and touch their infants has great impacts on parental stress. And the stress that arises from this parental role alteration, really, when looking into it further, comes from not being able to or know how to care for, touch, hold, comfort, or even protect the hospitalized infant in the varying acuity stages of their ICU course. 1 in 3 families are reporting symptoms consistent with PTSD, and these symptoms can remain elevated for up to 12 years post-CHD diagnosis, and arguably even longer. And we know that parental mental health is often a strong predictor of child mental health outcomes, sometimes even more so than medical and surgical factors. So really being thoughtful about how to support parents in this ICU environment is critical, as the stressors that are present for our infants certainly apply to parents and to families as well. Looking a little bit more closely about parent stress, the PCICU parental stress model developed by Lorenzi and colleagues really looks at the varying implications for stress for the infant, the parent, and the environment, and the corresponding parental stress responses, both psychologically and physically. All of these cannot be modified, which we understand, but the areas in which we can make changes certainly can be in regards to the parental role, and supporting and empowering parents to engage with their infant despite medical acuity, but in appropriate and sensitive manners. This parental partnership pyramid, which was developed by a group at Nemours, really investigated how parental participation in caregiving can be feasible in consideration of medical acuity. We've taken it a step further at Children's here in Pittsburgh, looking at how we can classify acuity on a more regular basis to guide parental engagement. So moving up this pyramid, you can see that the interventions are sensitive to the child's status at that time, and that should be discussed with the medical team on a regular basis, so parents are engaging appropriately and offering support in a sensitive manner, and corresponding very consistently with the developmental team, but also the medical team to offer appropriate supports. So moving along some of those other domains of developmental care that I mentioned, we need to speak about a little bit about positioning and handling in this interstage period. We know that there are motor impairments that are quite common for this complex CHD population that can be exacerbated by longer intubation periods and prolonged hospital length of stay. Musculoskeletal development requires adequate nutrition, proper infant positioning, and movement to prevent immobility-related developmental disorders and disabilities. Developmentally supportive positioning really hones in on 4 principles, which are flexion, containment, alignment, and comfort. And these can promote longer-term fine and gross motor skills, the ability for self-calming and self-regulation, energy conservation, and even head shaping and sleep hygiene. Additionally, awake prone positioning is crucial in this early period for development of head control and upper body strength, which is the building blocks for later developmental skills such as sitting, crawling, and even fine motor skills such as play at midline. All of these are areas we see difficulty for many of our patients with prolonged hospitalizations in the early period with univentricular lesions. The safety and feasibility of early physical therapy with passive range of motion or awake prone positioning, even after early sternotomies, has been demonstrated with improvements in motor outcomes in the long term. In this study here of holding and mobility with pediatric patients with transthoracic intracardiac catheters, they looked at over 1,300 patients and had activity and positioning documented with these catheters in place, and no major complications were noted resulting from patient mobility in this patient population, which I think is notable. There is great variation in holding and positioning practices across institutions when they've done surveys of developmental care for our pediatric cardiac ICUs. And so it's a growing area of that can be worked on to increase consistency and engagement in this area. Minimization of stress and pain and cue-based care are other really important areas in this domain. We know that undertreated pain can result in sensitivity to future pain experiences, altered stress reactivity, and longer-term mood and behavioral disorders. Integrating the use of non-pharmacological interventions like skin-to-skin care, closeness with family, non-nutritive sucking, this can prevent and even reduce infant pain when warranted, along with pharmacological management as needed. These interventions certainly demonstrate varying degrees of efficacy in reducing procedure-related pain in hospitalized infants. And there are a few small single-center studies that have reported the impacts in these areas with complex congenital heart disease, hopefully more to come. Cue-based care is another core component of developmental care. It involves reading the infant's behavior in regards to their attention, their state, their autonomic and motor systems, and adjusting the environment to whatever extent we can in the ICU to provide sensitive care and support infant brain expectations. Care often elicits stress responses, we know, and we've learned through the studies of often, again, premature infants that frequent activation of stress response systems can result in reductions of frontal and parietal brain volumes, reduced white matter maturation, and epigenetics changes. So attenuating these repeated stress responses through cue-based care can really have the potential to mitigate developmental disorders and disabilities in this patient population by preventing adverse stress-related changes in the brain. So timing, clustering of care, pacing of caregiving based on infant behavioral assessment and sleep-wake cycles can be really critical for neurodevelopmental outcomes. I would be remiss to not mention supporting feeding in terms of cue-based care. We know that infants with congenital heart disease and complex congenital heart disease at that frequently experience feeding interruptions because of invasive procedures, clinical status changes, hemodynamic instability, and use of sedatives or other medications, as well as the noxious hospital environment. And infants with CHD often lack the attention or oral motor skills and even the endurance to sustain oral feeding, and are at increased risk for further complications with outcomes such as vocal cord paralysis, diaphragmatic paresis, non-invasive positive pressure ventilation, poor intestinal perfusion, and even oral aversion. All of these feeding challenges stated, we can work towards more cue-based feeding models and engaging parents in the feeding practices, no matter what manner of feeding is being offered, to hopefully mitigate some parental stress that is often associated with feeding, but also to optimize feeding outcomes and demonstrate safe oral feeding. I'm just speaking quickly regarding sleep. We know that their sleep deprivation can have impacts in terms of loss of neuroplasticity, altered behavioral patterns, and sleep is so critical for healing and growth and for neurosensory development that practices for protecting sleep, such as clustering of care, proper positioning, being sensitive of the environment, as well as skin-to-skin care or holding for appropriate periods of time to allow for full sleep cycle completion, are all thoughtful interventions in this modality. Being aware of the CICU environment, the implications for neurodevelopmental functioning is also important, although sometimes hard to modify. The American Academy of Pediatrics recommends sounds under 45 decibels and never above 60, although our ICUs, with more research again in the NICU setting, but more coming from cardiac ICUs with decibel levels upwards as high as 120. And this can have impacts on growth and development. Cochlear damage can occur, or and other physiological implications and impaired sleep. Quick interventions to do would be rounding away from the bedside, monitoring of alarm volumes, and silencing of phones quickly, plus the delivery of positive auditory stimulation, where parents come in here, in terms of reading, music, and parental voices, with the exposure to language, which we know to be so critical for later communication development. Similarly, there are recommendations through the World Health Organization for the degree of exposure to light. And there's growing evidence to show that minimizing exposure to direct overhead lights, if medically appropriate, the shielding of the patient's eyes, and cycling of lighting and exposure to natural light during the day can have positive implications for sleep, for circadian rhythm development, and also for delirium management. One of the ways we've implemented many of these practices in our institution is with neurodevelopmental rounds. And this is based off of that developmental care framework we've been discussing. They occur weekly at bedside with a multidisciplinary team. We generate goals that are inputted into the EMR and are outlined at bedside with developmental posters. We really aim to have robust conversations with both staff and with families to talk about developmental progression and engagement in ways that we can normalize the ICU environment to still allow for growth in terms of developmental milestones, even when receiving this critical care in our ICU settings. And we've seen positive implications for infant-parent relationships, having more regular evaluation of the infant's behavior and the environment, and ultimately, with these developmental recommendations, hopefully easing the transition to home. And this is not a one-person job. It's a multidisciplinary venture for sure. We work closely with physical and occupational and speech therapy teams, with child life, with behavioral health, and like myself, and along with our nursing and medical team colleagues. And this really is a team effort to implement some of these neurodevelopmental care practices in our ICUs, but we know that the outcomes that we can see later on can certainly be improved by really being thoughtful about the interventions offered in this critical time point in the early stages. So I really appreciate the chance to speak today. I apologize for not being able to participate in the panel, but please direct any questions my way regarding any of these topics. So thank you so much.